Good afternoon, everybody. Good morning if you're on the West Coast. We are about to start a National Action Alliance national webinar called Making Patient Safety a Core Value, Building the Foundation. We have a number of participants, including some people that we can hear speaking in the background. So please mute your lines, your participation here, so that you're not interfering with the presenters that we have today. So we're very excited to do this webinar. We're going to get going right away. This webinar is going to be recorded. If we could move to the next slide. And the voice you're hearing is mine, or you should be hearing is mine. I'm Marty Hatley. I'll say a little bit more about who I am in a second, but we are have a few housekeeping things. This is not a place where we're going to, not a webinar where we're going to be able to take live questions. We have three pithy presentations. We're going to get through them. If you have questions, we're very interested in hearing them. Questions, comments, feedback. If you could use the chat to do that, we would appreciate that. And Jay Perdue and Melissa Bottinger from AHRQ will be monitoring the chat and helping me kind of tee up the comments and questions that you've got for our incredible slate of speakers today. Closed captioning is available. There's instructions that you see on the screen right now for how to do that. If you need help with that, again, I would put that in the chat, and hopefully we will have someone to be able to help you with that. Next slide, please. I think this is where I introduce myself. I'm Marty Hatley. I am a longtime patient safety advocate. I am currently the Director of Policy and Advocacy for Patients for Patient Safety US. We are still hearing background noise from Lisa Kuska. If you could mute your line, Lisa, that would be very helpful. I'm thrilled to be here today because I was involved in the technical expert panel that put together the change package that you've heard about already through a webinar that was for those of you who attended a webinar when it was launched last September. And this is the kickoff of a series of webinars this year to really focus on how this aligns with the work of the National Action Alliance and the other things the National Action Alliance aligns with. So welcome everybody, and we're looking forward to a really rich and helpful next hour. Next slide, please. And I told her I would just keep her up to date. One more time, we really are hearing interference from people. Please mute if you're a participant. So just a little bit of level setting here. The National Action Alliance is a network of committed organizations that are in action on patient safety. We ask for 5 things as a part of this alliance, and that is that you pay attention to the 5 things you see listed here: advancing organizational strategies, empowering the patient's voice, supporting the workforce by design and with competencies, and then facilitating and learning from one another. We are an all teach, all learn network of people that really are committed to raising the boats of all of us for all the patients we treat in the United States. Next slide, please. There's been a lot of activity on patient safety in recent years. I think many of you are familiar with some of these resources, but what's been notable from my perspective as a patient safety advocate is how much our different agencies have tried to, and our different private sector organizations have tried to align together around common strategies. So one of our guiding documents is Safer Together. It's the National Action Plan for Patient Safety. It's been around for a couple of years, but it's been really renewed and reinvigorated in recent years. The 4 foundational areas have stayed the same. It's cultural leadership and governance, patient-family engagement, workforce safety, and learning, organizational learning and collaborative learning. So those are the 4 things that we are focused on. There's a lot of tools at the AHRQ website. You see a hyperlink also to the IHI website. IHI has been a partner with AHRQ in leading this initiative. I think many of you probably know very much about it because you've heard a lot from us in recent years. I'm on the National Steering Committee, by the way, of this action plan. Next slide, please. So one of the newer developments in this field is the patient safety structural measure, and I'm betting there are some people here who are not that familiar with it because this is a new measure that went into the CMS quality reporting rules in 2024. Last year was kind of a getting ready measure, and next month, is it February yet? No, it's March, I believe. The first reporting portal opens up for this structural measure. It has 5 domains. Each domain has 5 attestation statements, so there's 25 overall. And as of this year, hospital leaders participating in the Medicare program are going to be asked to attest to whether or not they have these 25 best practices in place. And there's been yeoman's work to sort of map these attestation statements that we're gathering data from starting this year to the strategies and the resources that AHRQ has in the National Action Alliance and also in the National Action Plan. As I mentioned, the reporting portal opens up in March, and the data will be scored later this year, and we expect to see some publicly reported scores on these measures as early as September. So, and they're not for the faint of heart. Just like the presentations you see here today, some of them are pretty robust things that we're going to be asking whether hospitals have these in place. So the presentation of these 3 high-performing hospitals today could not be more apropos. Okay, next slide, please. So what we're talking about today is a change package, a series of best practices that were harvested through a long process, a long methodology that AHRQ put into place. Houston Methodist, Mayo, and St. Luke's University Network popped to the top of organizations that were really high performing. They were gathered together last year in an effort to really harvest their lessons learned and turn that into a change package, a series of concepts and strategies that can be useful to all of us. And we're excited to be digging into some of those with our 3 high-performing systems today. Next slide, please. Just to give you an example, a little teaser of how this is structured. There are these change concepts. Again, they were harvested from what's actually really happening in the search work that AHRQ did, and the 3 systems in particular that we're talking to today. So the first change cop is safety is foundational, and that maps to actionable examples that you could implement in your organization or perhaps are already implementing. Multidisciplinary rounds and bedside shifts are a good way of communicating to patients and families that this is foundational in your organization. Psychological safety through recognition of people that of the workforce to encourage safe care. And a real emphasis not on personal fault, but on looking at the way work is designed to set people up to succeed or fail. An emphasis on reporting. Reporting is our treasure. Reporting of safety events, which is often hard to do, is important for us to have the kind of continuous learning that we're committed to. Using data to drive improvement. You're going to hear some wonderful examples of how organizations are doing that very, very systemically today. Providing robust training opportunities and supporting communication from the top of the organization to the bottom to the top on a real-time daily basis. So just a number of different examples here of what is in the change package. Again, this is just a teaser of what you're going to hear from some other people today. And it's a fantastic resource available on the AHRQ website at the National Action Alliance page. Next slide, please. Well, as you listen today to the presenters we've got, we're really hoping that you will ask yourself these questions, reflect on these questions, and perhaps think about how you can take content from this webinar to really work on things that are happening in your organization. So these are the questions we'd like you to think about. What actions are you hearing today that are most exciting, and what will you take away today and do in your organization? Next slide, please. It's now my great pleasure to introduce our 3 showstoppers today, our 3 highly committed leaders in the organizations that are performing as well as we could expect any organization in our country to perform at this point in time. So I'm thrilled to welcome them. They were members of the technical expert panel on safety, culture, leadership, and governance that AHRQ convened last year and that produced the change package. And they are all leaders with terrific experience. So I'm going to start with you, Sean. Sean Tittle is the Senior Vice President and System Chief Quality Officer at Houston Methodist. His leadership spans areas such as data analytics, clinical informatics, infection control, and accreditation. Sean is a thoracic surgeon. He also has an MBA, and he's been with Houston Methodist since 2016 in various leadership positions, including Chief Medical Officer and Chief Quality Officer. Donna Sable from St. Luke's Network has more than 15 years of experience in overseeing quality there. I met Donna for the first time today. She was a virtual participant in our meetings last year. She has administrative responsibility for a number of network functions, including care management, clinical documentation, coding, as well as quality. She is a master's level nurse, educated nurse from DeSales, and holds a professional certification in healthcare quality. And last but not least is Pauline Byam at Mayo, where she has 28 years of experience at Mayo in quality and systems improvement. She's been instrumental in operating their culture of safety work, which I think you'll highlight for us today, Pauline, including tiered handles, digital visual management boards, a number of different strategies that she will share with us a bit today. She holds an MBA from Viterbo University and certifications in healthcare quality, Lean, and Six Sigma. So please join me in welcoming these three phenomenal people here. We're lucky to get their time today. And Sean, I'm going to turn this over to you as our first presenter.
Excellent. Thank you, Marty. And thank you so much for your incredible leadership on patient safety and your nonstop advocacy. It's such a pleasure to work with you and the rest of the team here. Hi, everybody. I am Sean Tittle. I'm really going to focus on the first two concepts in the change concepts, and that is safety is the foundation of patient experience and how we prioritize the psychological safety of the workforce to encourage safe care. We'll go to the next slide. I want to show you the slide that we use internally at Houston Methodist before we start any strategy discussion. And that means from the CEO all the way through the entirety of the organization. If we ever talk about strategy, we lead with this slide. And this slide is our vision for the second century. We turned 100 years old in 2019. And as we focused on what made our first century and we thought about what we wanted to be in our second century of existence, it came down to 6 simple words: unparalleled, safety, quality, service, and innovation. And we always start with safety because we feel that that is the core driving factor, the core driving principle behind all the decisions that we make at Houston Methodist. And I also want to add one other comment on this, which is and is capitalized and bolded because and is one of our core principles. It is not or, it is not safety or quality, it is not safety or service, it is and we always focus on the and. Next slide. This is another internal slide that I'm sharing with everyone. It's a very busy slide, I understand. But this is a core component of what we call pathway to unparalleled. And every year, every employee, including physicians and APPs, and all of our nurses and all of our bedside healthcare providers, administrators, everyone in the organization is expected to attend a session called Pathway to Unparalleled. It is a 2-hour session. It is anchored by video vignettes. There are multiple stories, usually around 4, and they identify a particular topic. They're all centered around something, like they're all centered around safety. They're all centered around quality. They're all centered around innovation. And these stories involve the caregivers, the administrators, the patients telling the stories, and they come back to what makes our culture important, what makes our culture central to the way we deliver care. In addition to that, there is approximately 40 minutes of discussion inside that 2 hours. And so there's guided conversations with questions and answers. And you see our I care values run throughout, and it is about safety, quality, service, and innovation. And I will share that cadence with you on the next slide. So if you look at this, you can see our path to today and our path forward. And this is last year's slide, but you see the topics that we use to drive this. The photograph in the left was from about 10 days ago, and that was literally the working group of leaders that were brought together to plan the 2026 Unparalleled Service stories and vignettes and guided questions and discussions. But you see in 2023, Unparalleled Safety, safety was a core component of this entire process. It was around which we did the entire program in 2023. We're doing it again in 2029. So we have a regular cadence where we reinforce through a system-wide 36,000 people 2 hours. It's always in the autumn, and we have this every year. That is a key component of how we drive culture. Next slide. Additionally, a couple of more easily actionable things. I was looking specifically for things that you could roll out that were cost-free in your organization, and you could start immediately, one of which is voice of the patient. So we use this as the first agenda item in many of our high-level meetings, meaning is the board involved with the meeting? Are senior leaders involved? Let's start with voice of the patient, and it is generally safety focused. So we will tell a story from the perspective of the patient regarding their safety, quality, service, and outcomes. And it is always a cornerstone opening event in our annual safety and quality symposium where we talk, if possible, we have the patient themselves come and present to our entire symposium audience about their experience and what it meant to feel safe and recipient of high quality care. Next. Serious safety events. When we talk about safety, I'm sure many of you do this. The committee is chaired by me as the System Chief Quality Officer, where we talk about every one of our serious safety events, and we talk about our action plans, and we talk about how we close the loop. The important aspect of this is every single one of our serious safety events ends up as a vignette, and every single one of those vignettes is presented to the board of directors of our system. And so the board sees every single serious safety event, every single RCA in a condensed nutshell, and every single action plan on how to address these. So at the end of the day, all of our events are showed to our board of directors in the spirit of complete transparency, and we use this to drive psychological safety and to really show everyone that safety is at the forefront. Next slide. We have our good catch, same first order of business at board-sponsored quality meetings. After the voice of the patient is the good catch. We don't try to promote the hero culture. However, we do very much want safety to be at the forefront. And so we have certificates, awards, photographs with the members of the board, annual luncheon celebrating these safety award recipients. And we have an annual Greatest Catch Award that comes with a financial prize as well. Finally, I think we have one more slide. Safety, quality, service. We rebranded our department. So we are no longer quality and patient safety we are safety, quality, and service. Safety is the first word in the name of our department, and that was something that we accomplished this year and we were very proud of. Thank you for the opportunity to share this quick vignettes with you and these little strategies. I hope they help you. And it's been an honor to be part of this committee.
Marty, you're muted. I'll just take over for myself if that's all right. Hi, everyone.
Sure, please do.
Thank you. From Mayo Clinic. Happy to join everyone today. I really appreciated Dr. Tittle's lead-in on from Houston Methodist and how they prioritize safety in their core strategic goals. For 150 years of strength at Mayo Clinic, we've thrived on the deeply experienced teams who deliver that category of one care. I think we all felt the big disruptor of COVID and other things, and we're not immune to losing some of that experience and collective expertise. Today, we're facing a different landscape. We navigated critical staffing challenges and faced with a generation of less experienced staff that are also, we're asking them to pursue the same excellence with the same institutional depth. The way we learn, communicate, and absorb information is changing rapidly. Staff are looking for meaning in their work and to feel their contributions are valued and respected. I'm in a lot of our leadership meetings, particularly in our culture of safety work. And as we look at our biannual culture of safety results, and we're getting some feedback that staff weren't seeing that visible manifestation that we care about their safety and we care about experience of care for patients. We also have a lot of the same practices. I think you'll see some commonalities between all three of our organizations on starting meetings with a mission moment or a patient story around experience, safety, quality of care, things that we're striving for innovations and ways that we're impacting the care we provide to patients every day. But we need to make sure we're taking some concentrated efforts that trickles down all the way to the frontline caregiver and the frontline care team members, including the environmental services staff and food service staff and those that are providing care to the caregivers themselves. So how do they see it? How does staff feel that leadership commitment and experience of care? And I would argue focusing on safety and quality are the main reasons people work in the medical field in the first place. And so harnessing those as priorities are huge motivators for staff when you talk to them. And at Mayo Clinic, we cannot assume quality, safety, and experience are assumed priorities. We take great pride in the ratings and rankings that follow some of our contributions and commitment to safety, quality, and experience, but cannot rest on our laurels and assume that those ratings and rankings are always going to be there. And so it's a concentrated effort year over year. They are front and center in our strategic priorities year after year as well. I think each one of our organizations, and we talked about this in the first webinar last fall, have an acronym for our values and how we live those out. And I'm going to talk to you about a little bit about how we talk about the behaviors specifically and structures that we would want to see at Mayo Clinic. So go ahead to the next slide. So I think we've all been here before, and we talk about this a lot, those that are professionals in quality, safety, and experience, that we want it to be everyone's job, but we all are in different stressful environments. So even on our bad hair days, we need to bring our best selves to work and how we support each other in that work. The policies, the procedures, even the strategic plans are really important, but they don't live there. They don't live in the print. They live out in the everyday decisions and even sometimes the awkward conversations. And quality isn't something that you can assume, but it also cascades through various levels of leadership from top to the frontline leaders and even each other. And how do we hold each other accountable for the things that keep patients safe? I'm going to talk to you a little bit about what we know from patients and some research that we've done about how patients perceive safety of care. And I would argue it's in a lot of the little things that we need to hold each other accountable to every day. So go ahead to the next slide. If you've been in any work in patient safety for a while, you've seen this play out over and over again. Something feels off. Maybe we're not following a policy or something is wrong. Everyone notices it. No one speaks up. Later, we feel like we should have said something. And the caregivers, the patients, their families, everyone's replaying that Netflix over and over again. You weren't planning to binge it, but you're playing it over and over again with the what ifs, could haves, and should haves done. So what do we see in those examples? Fear of being wrong, speaking up is their hierarchy, fear of consequences. There's also time pressures. We have an insatiable demand for services. We're not a unique in that. And also feeling like someone else has this. Someone's going to catch this at some point along the chain, and it doesn't happen. And expecting that you don't need a leadership badge to prevent harm. You just need courage, and you need to maybe take a deep breath and speak up and say something. So what happens when you see that acting out is the concern is raised and the response to that is supportive. Dr. Tittle talked about this, how we respond in the moment. The first thing is thank you for bringing that up. You're receptive to somebody else receiving that. When you see that not happening as a frontline leader, how do you intervene and make sure that you're creating that welcoming environment? And it is more critical than ever for some of those circumstances that I mentioned with our inexperienced staff who maybe aren't as sure of the things that they're doing every day and feeling as confident as our veteran staff maybe would have over time. And through those things, trust grows. And the more people don't stop speaking up because they're wrong, they stop because nothing happens when they do, or they're speaking up and their concerns are ignored. So how do we respond to that? Go ahead to the next slide, and I'm going to bring both sides of this. This is from the staff's perspective, but also talking about some research that we've done with a company I call them a colleague, but a company that we partner with called C-Space Health. Mayo Clinic patients come from all over the globe, so it's a little bit more challenging for us to get insight from patients all over the country, all over the globe, not necessarily in person in our traditional PFAC approach that we may have done in the past. So we're fortunate to have a partnership with C-Space and asking them, what does safety look like to you as a patient? What are some of the cues that you see to know that you're in a safe environment? And even what are some of the cues to say you may not be in a safe environment, or things that maybe make you more concerned or on edge? And I think that these insights were really helpful for us because it's in a lot of the little things that I would argue some of us feel like are repetitive tasks. So the times that we repeatedly check that patient ID in every transition of care, every time we give a med, every time we draw blood, every time we're moving a patient from one place to another, that we might think that's a repetitive step and that might be waste in the process. Patients view that as safe care, that we're repeatedly following those, and they notice when we don't. So if this is a safe practice and they're expecting that when they receive care from Mayo Clinic, we notice when they don't do it, when we don't speak up or we don't ask those things. And the other thing that I think was really insightful in this research is the environment of care outside the care inside the facility. So how we provide safe parking, how we provide lighting, how we provide security presence. We've had internal debates about weapons detection screening at our doors, and does that create an uninviting environment? And feedback from patients is they want to feel safe and they appreciate the efforts that we're putting in to making that visible. On our last culture of safety survey and questions around workplace aggression and staff feeling safe so that they can provide safe care, providing that visible investment in their safety and visibility to that was one of the call outs as things that they have seen change as a result of the culture of safety surveys and the feedback that they've given. So, and also providing, I don't think this aligns with safety also being so closely connected to the patient experience, that how we provide good, detailed explanations of the care and each step of the process is really, really important to our patients. Go ahead to the next slide. And I'm going to talk about just a few things on this slide about ways that in recent years we've made more and more of our commitment to safety really visible to our frontline staff. So we identified ways that we measure safety. We have been using something called the Mayo Clinic Value Index for over a decade that takes a lot of our ratings and rankings and things that are out that are super complex for patients to navigate. And we created something called a health locator that is a free digital tool to help patients and families find hospitals around the country that consistently provide high quality care. We use a combination of publicly available data that prioritize improvement efforts around safety and experience that we've used internally. And as a quality professional, and struggling to distill all these ratings and rankings into something meaningful internally, we needed to create something that is also easy for our patients and our staff and families from all over the country to also navigate. We also struggle to provide care to everyone that wants to come to Mayo Clinic. So how do they find better care closer to home? Our leadership invested in this tool, and instead of creating it as a fee for service and needing to collect your email addresses and things, they provided that as a free service to anyone around the country to look up high quality care closer to home. That's a financial investment that was highly visible to our staff and to our patients. We also identified what you see as a picture on the screen is one of our teams huddling around a digital visual management board. We doubled down on tiered huddles and investment in a way to make it easy and transparent for bi-directional communication for things that our staff needed to escalate up for help in problem solving, but also being able to close the loop and cascade those down. By the end of first quarter of this year, we'll have 220 of these digital visual management boards up in every inpatient nursing unit and every surgical core across all of our Mayo Clinic locations. So a huge investment, and 2026 will be the year of maturing our tiered huddles and maturing that investment. And we've resolved, even in last year, as we were rolling these out, over 700 issues were escalated by our staff that we were able to resolve in 2 days or less. And so the things that are those pebbles in the shoes that staff are struggling with, we're able to escalate those and cascade those learnings down. There's also capabilities to cascade learnings from safety events and also make it transparent that we are addressing those issues. I conducted multiple listening sessions after our last culture of safety survey, and an interesting insight from our staff was I bring up an issue to my supervisor, I see them write it down on a Post-it note. Did that note go in the garbage? Did it get on a spreadsheet somewhere? What's the status of that? If you submit a ticket to the help desk, I know what's going on and the person that's working on the ticket knows, but no one else knows within the sphere of around us. So we're investing in that, and everyone can see what is being issued, escalated up, and what's escalating down. We developed a maturity matrix to specifically identify behaviors and attributes of a huddle that you would see if you were at a beginning stage or you were optimized, and developed a pathway for leaders to bring their huddles along that journey. Culture of safety isn't binary. It's not a yes, no, or a pass, fail. It is a spectrum, and we want to meet people where they are and meet teams where they are, but also help them through coaching and identifying key behaviors that you would want to see. When you look at a huddle and somebody says, is there any safety issues that people want to bring up today? What do you see happen in that environment? What do you hear? Do you smell fear using your 5 senses? What are those things that you can tangibly pick up on? And we needed to put those down on paper so that people understood it wasn't just our values on that we espouse to, but what do those look like in action? I'm going to turn it over to Donna now to talk about how St. Luke's is doing some really creative things to keep it alive and keep the culture going.
Thank you, Pauline.
Thank you, Pauline. Hi, everyone. So, I get asked all the time, how do you keep this at the forefront? How do you keep it going? Because as Pauline had in her slides, this can't just live in a policy. It's something that has to be really tended. So it has to be a leadership imperative in our organizations. And I say something here at St. Luke's all the time, that if you want high quality, a safe environment, to be at the top of your game in patient safety, it is like a beautiful garden, right? It has to be tended, it has to be watered and weeded and fed. And so it is the leadership imperative to do that and to keep the focus in an organization. All three organizations have our vision statements. We all have our values, but again, they can't be in a book on a shelf. They have to be lived every day. And I think this is one of the greatest challenges to continuing to grow and improve and provide high quality, great patient safety in an organization. Next slide. Thank you. So one of, the change package governing statements is that leaders set expectations of excellence and safety. And we all have our principles that we live by across the three organizations that we discovered, some of them a little bit different, but many of them the same. So one of the things that is outstanding, I think, in the three organizations is that the culture really focuses on people and relationships. And that can be from the standpoint of, developing others, high levels of communication, and psychological safety. I think leaders are our most important element of our businesses and are in a very high demand and a short supply. So, how do you mentor, develop, and create succession planning in your organization? We grow our own here at St. Luke's, and it's important to us. And one of our key imperatives is to keep this culture of safety strong and moving forward. So we have to have the right leadership, again, to make that happen. We talked a little bit about data. So, it's key to maintaining transparent, accountable management. That speaks to our integrity. So are we doing what we say we're going to do? Do we engage our staff and our leaders in understanding where the performance of the organization is as it relates to patient safety, and focusing and shining the light on what we need to do to improve? And then keeping a flat structure, I think, is important. So bureaucratized decision-making doesn't help with agility and the ability for an organization to address issues in a timely manner and to do that in an efficient manner. And then being integrated across the system. There are a lot of healthcare networks in the country, but are they truly integrated? And on what components have they integrated? So being able to have a consistent, seamless system of care delivery and focus across an entire healthcare enterprise, I think, is really, really key. Next slide. And then this next principle of leaders caring for their people. So I think Sean mentioned, and so did Pauline, the aspect of psychological safety. Nothing will shut down, I think, an organization's ability to improve patient safety than people being afraid to speak up. So, Pauline mentioned that people are afraid to make mistakes. I think the messaging of, the fact that you're going to make mistakes and you have to own them and learn from them is key. And our CEO messages that consistently throughout our organization. And to be successful in healthcare requires risk-taking, especially in the challenging environments that we have. And when you are retooling processes or your system, you're going to naturally have wins and failures. If we go into risk-taking thinking we're going to win all the time, it's just not going to happen. Strong mentorship, again, in succession planning, I think is key. And then being able to speak truth to power. So creating a message to our staff, our physicians, all of our providers, that we value candor. We want to know what is going on, that we can have productive disagreements, and we can have free exchange of ideas. You know, I might not always agree with the decision that's made in our organization, but I have the opportunity to hear and understand why decisions were made, and you know, then to understand that it's my job to support that decision. Leadership visibility, can't say this enough. So again, how do you keep this going? Every one of our hospitals, our hospital presidents, our chief nursing officers, our quality directors, our physician leaders at each campus are visible and rounding on a consistent basis. And what they're doing is proactively inquiring with our staff. What is going well? What isn't going well? Expressing appreciation for what our staff does every day, acknowledging opportunities. And to Pauline's point, you've got to be able to close the loop and circle back. Having zero tolerance for disruptive behaviors. You know, folks don't like to talk about this, but it's one of the key things, again, that can shut down someone's willingness to stop the line when something isn't going right. So, you know, assuring that even your medical staff leaders are addressing disruptive behaviors that may present themselves from your medical staff. Creating, you know, within the nursing hierarchy.
Because you don't have enough medicine.
You know, skilled nurse managers.
But you're not
who
supposed to
are
wean off.
really
No.
well trained.
Thursday. Friday's dangerous.
Lisa,
Thursday's iffy.
Lisa, Kusta, can you go on mute? Thank you. Making sure that your managers and leaders have the skills to address disruptive behaviors and to do that in a timely manner is really, really important. And then how do you measure whether you're doing a good job with creating psychological safety? Well, our culture of safety survey results, certainly, but also staff engagement surveys. And at St. Luke's, we have extremely high staff engagement. So I use that as a good metric in terms of how well we're doing creating a culture where people feel they can speak up and they know what's going on. Next slide. And then again, caring for our people, our staff. I think sometimes we take what we do too seriously. And at St. Luke's, we try to create some brevity and have some fun in celebrating what we're doing because, you know, healthcare is not for the faint of heart, right? So being grateful for the organization, being grateful for the leadership, being grateful for the providers and the staff, and showing that gratitude is really, really time well spent. In my conference room here right now, I have a board which, you know, says I am grateful for, and we put Post-it notes on that. We're grateful for many things. So I think being able to express that and enforce that is really, really important. Celebrating successes, and we don't do that enough. So we do have an annual quality awards program that we've been doing for about 17 years now. We announce first and second place team winners at an annual quality awards program in October during Quality Week. We announced the President's Award for Quality, which is really highly sought after. It creates very healthy competition within the organization. And you will hear our staff and physicians and leaders saying, you know, I want a quality award. And so we also use these projects then to submit to our state award program and to national conferences. This year we had 79 projects submitted from our network. And I like to tell people that, you know, you have to teach your children well, right? That's from a song, for those of you that are as old as I am, from Crosby, Stills and Nash in the 1970s. But what do I mean by that? You know, getting your residents involved, you know, your GME programs being highly integrated, teaching them how to do this and why it's important and of value. Nursing students, medical students, you know, really engaging them early on. So in our quality awards program this year, we had over 30 projects that were submitted from our residents and fellows. And no one is happier than a resident or fellow when I call them to tell them that they've won a quality award. They just get so excited. And then we support them in helping those projects get published. Keeping it real requires, I think, safety to be top of mind on a continuous ongoing basis. So adding safety as a standing agenda item for every service line quality committee meeting, every department meeting, our nurse executive meetings, it is just a standing agenda item where we're seeking input and feedback from our staff directly and closing the loop on items that have been identified that we need to give feedback on. I already talked about daily rounds. And what you're seeing here with our little polar bears, this is a thank you card that is designed every month. It's a different design. It's very creative, and we send these from our patient safety officers. This one happens to be Stephanie, Sharni, and Jordan at our Bethlehem campus. And we give, very creative, and we always have a little tidbit and a focus area. So this goes to each person who submits an event report that month. And, we will see them posted on the units. And we're using them to really acknowledge and close the loop so that people don't think that an event report goes into a black hole. This has been really effective, and we've been doing this for several years now and get very positive responses. The cards are put together by our administrative staff here in my office, and then they are sent to the specific campuses and distributed out from there. So a lot of fun.
Somebody said
And I think that is my last slide. So again, just engaging your leadership valuing, creating daily processes through rounding, always a topic. And just one thing, you never rest on your laurels. So I learned something from Pauline's slides and shared with my network director for clinical risk management. We don't think enough about how patients and visitors view our environment. And we actually have valet parking, and our valet staff are always smiling, always greeting. And I was just talking to one of them today and acknowledged that and said, you're always so happy. And he looked at me and he said, you know what, Donna, people aren't coming here for fun. They're coming here because they're dealing with something serious. So if we can greet them with a smile, we think that helps them. Talk about ownership and, support for the organization and for our patients. So that was something today that I felt a lot of gratitude about, our valet
Great.
park. Little
Thank
things.
you, Donna.
All righty.
Okay, thank you, Donna, and thank you, Sean, and thank you, Pauline. We're getting lots of very practical questions in the chat from many questions. So I think you're giving people very practical ideas about what's happening. Just a quick comments from me, Sean. I love the SQS. I mean, as a patient, having safety be the first letter in that acronym really speaks to me. That's really what I want to be the first and foremost thing that I think my healthcare providers are keeping top of mind. And I love the long planning with the reinforcement of safety years in advance and the reinforcement by repetition of that as a theme. I thought that was brilliant. Pauline, you said a lot of wonderful stuff, but your visibility manifestation boards, people wonder where they are, who sees them, that sort of thing. I'll ask you about that in a second. And, I think I heard from you, Donna, and from everyone, the importance of visibility and communication up and down the chain as being really important to the cultural work that you're not only building, but sustaining. And I think that's a big challenge for all of us, is just seeing the kind of work you do sustained over time. So you've given us fantastic ideas and practical ideas about that. Jade or Melissa, are there questions in the chat that have really struck you as important to tee up for Sean, Pauline, or Donna?
Yes, thank you, Marty. In the chat, we've had a lot of
really wonderful comments and many questions. And if you're okay, I'll just start with a few of those.
Please.
This one was directed to Dr. Tittle. Can you discuss approaches to educate and move the culture of the board to embrace safety as a top value and shift from blame and fear to transparency and improvement?
Great question. The first thing I want to say is I'm very, very grateful to be on a panel with Pauline and Donna. They are incredible leaders. And every time I hear them, I learn something that I take back and operationalize almost immediately. The second thing is it's been a process. Really, this has been a 15-year process for us with our board to make them more and more not only just involve, but own and lead safety. So our quality committee of the board is led by our vice chair of the board. And I was on a meeting immediately before this webinar with our vice chair of the board talking about our safety quality meeting agenda that comes next. So that kind of relationship building between the quality team and the board is incredibly important. And the fact that we reiterate concepts like psychological safety and the necessity of high volume reporting of things that are not going well at the bedside. These concepts are not foreign to the leaders that we have on the board. And I imagine your board is the same too. They're thoughtful, intelligent people that have been handpicked out of your community. They're going to understand these concepts. So just keep that conversation going. And if possible, encourage members of your board to lead a committee that has to do with safety and quality. They will do their homework and they will become your biggest advocate.
Thank you, Dr. Tittle. I have a couple more questions. One is from Jean Ann and another is from Christina George regarding Speak Up. Essentially, how are leaders mentored to respond to increase the courage to speak up? And then secondarily, how do you ensure that perspectives of both leadership and staff are engaged and committed to speaking up? Does anybody want to take that one, Pauline?
I'll take
or Donna, go ahead.
Again, I think, when safety is a number one priority in an organization, I think it just flows naturally that you identify the things that your leaders have to be very skillful in. So how to have crucial conversations. We do a lot of book clubs, and that is one of the books that we've used. We give direct feedback to our leaders, and we seek it. So especially if I'm dealing with a really sensitive issue in a meeting, I'll usually reach out. I have my kind of safe haven people who I know will not just tell me I did a good job, but will tell me what I could do better. And so I think that ongoing development of your leaders with continuous feedback and mentoring is key. And then having select topics. So our physician chairs, I'll use our orthopedic surgeons, they do book clubs again on all of these topics so that we're getting our medical staff skilled in how to have these conversations and address these issues and address disruptive behaviors and even with each other. Mentoring each other. I joked with our chair of orthopedics that I wanted to be a fly on the wall when he did the book club on crucial conversations. But I think, you just set that expectation, have that permeate your organization, and then it becomes part of the fabric of the organization.
Thank you, Donna. This question was also directed to Dr. Tittle. Please comment further on how you follow through and track results of your action plans.
Somebody out there is reading my mind, I think. I think this is a huge challenge for all of us, especially if you have a high volume of serious safety events. And I think all of us do that we look at. It's nearly impossible to close the loop on everything. And it's also a challenge to come up with robust action plans. So we've taken it upon ourselves to elevate our requests in our action plans from every entity, where we've scored different interventions, right? So education is actually the lowest scored item. And so we'll ask people to reach a threshold score of their action plan. And so you can do education in 50 different ways, and it might not necessarily meet the scoring that we're looking for. Secondarily, we, you know, I really don't like death by meeting. We're really not a fan of over meeting. And yet I I sunsetted a couple of committees to restart one that is purely focused on our action plan. And so we have a committee that meets with our quality directors and our chief quality officers, and it is purely a loop closure meeting. And so we will approach things like an A3 where we have a timeline and we have deliverables by a certain time, green, yellow, red, on where we are and whether or not we need to divert additional resources to any of these things to make sure that our most meaningful action plans or our most significant or frequent serious safety events are addressed. And I think that making sure that we close the loop is maybe one of the most important things we do. I hope that helps and answers your question.
Thank you. That was great. This next couple of questions are directed at Pauline. There was a lot of interest in your tiered boards. Folks were asking, where are they located, if they're visible to patients, and if they are visible to patients, are patients incorporated, or how do you explain them to patients?
Yeah, thanks for the questions. We started by putting boards where people naturally huddle. So because we wanted them to use the boards as communication vehicles and for escalating and recording staff's input. So there's a mix. They're in huddle rooms that staff units, they are out on the units. And we also have tiered leadership boards where things can escalate, and we can use them in a venue like this to look at things that people escalate. So it's a mix of public and private areas that staff use. In our surgery area, staff are or patients are often not awake when they're being wheeled by a board, so they wouldn't be able to see them. But the boards, it's a vended product, and the boards do have a kiosk mode. I did reach out to a colleague because I saw that question about if we've received any patient feedback or questions, and we've had a few patients ask about the boards, and the team can select which things go into a kiosk mode and which things the patients see. And often patient comment for just anecdotal feedback is they appreciate that we're working on safety and trying to improve safety, because the things that they're showing on those boards are the things that staff are trying to work on. I did see a question that kind of is loosely related to that on how we measure safety. I think we're at a tipping point in the industry where we've spent a lot of time measuring absence of safety and not enough time measuring safety. And so we're really doing some in-depth work at Mayo Clinic on human resiliency and trying to learn from the workarounds and things that staff are doing, so that we can understand how to mitigate and keep things safe when they don't necessarily always follow that checklist or algorithm or process that we would expect them to take. So we're spending a lot of time in that space, but also starting to produce more measures in the system on when staff are doing things like checking the lines and good bedside handoffs and things like that. And Donna talked a lot about recognizing good practices and rewards and recognition, and trying to work more of that into the process.
Yeah.
Thank you, Pauline. Marty,
Jane,
do we have time for one more?
I was going to just to interrupt and say I'd like to ask a question before we leave. We're a minute away.
Ahead.
But just to some of the points that you were just talking about, Pauline, and Donna, you as well, visibility about safety, about your commitments is so important to generating that trust and patients. And when we talk to patients, which we gather in systemic ways in my organizations, they want to see that attention in various ways, and they want to know how they can escalate. They don't, that's where my ears perked up is how much of those visible boards they can see, because there's still fear about speaking up, especially if they're going to report something that's disruptive to them. But they want to know, they want to have those opportunities, and the more visible you are, I think the more trusting they'll be that they can speak up. So I hope that's helpful to you. I think that visibility and trust connectivity is so important, not just for staff, but for the patients who come in as well and their visitors. I mean, just seeing data posted someplace tells them that you're taking this work really, really seriously. So thank you. Thank you all. Jade, we are at time. I know that's important. We're in fact 43 seconds over time, but please everyone join me in thanking Sean, Pauline, and Donna today for really practical, wonderful solutions. And this is the first, I guess the second in a series, but the first in the series this year of more webinars like this to come. You can register for all of them, so please do that at the AHRQ website, the National Action Alliance webinar website, and we'll see you at the next one. Thank you.